Abortion providers often abandon women who suffer complications from their procedures to be treated by other facilities. This problem has grown since the reversal of Roe v. Wade, as abortion centers in pro-abortion states seek to attract out-of-state women seeking abortions. Lozier Institute's Vice President and Director of Medical Affairs, Dr. Ingrid Skop, has first-hand knowledge of two examples illustrating this problem.
A young Black woman traveled from Texas to an out-of-state Planned Parenthood where she received chemical abortion pills. She took mifepristone the first day and misoprostol the second. The third day, she bled heavily and passed an embryo in the shower. She immediately began to experience left leg pain. After traveling home, the pain worsened, and she began to feel sick. In a Texas emergency room, she was diagnosed with a left deep venous thrombosis and sepsis, a serious infection in her blood. She was admitted to the ICU, where she received anticoagulants and antibiotics. Ultrasound revealed remaining pregnancy tissue in her uterus, requiring an additional course of misoprostol. She spent a week in the hospital.
In another case, a young Hispanic woman traveled out of state from Texas for an abortion. She stated the provider did not counsel her about the option of surgical abortion, merely recommending abortion pills. She took the regimen and began bleeding. The bleeding persisted as she drove home and continued daily for 2 months. Finally, she went to an emergency room, but the physician did not recognize the nature of her problem. Her pregnancy test was negative, but this did not reveal the retained dead pregnancy tissue in her uterus. Returning to the ER several days later, ultrasound revealed the retained tissue. Dr. Skop performed a surgical suction aspiration to remove the tissue, finally resolving the patient's prolonged ordeal.
Similar scenarios likely play out countless times each year, as doctors and emergency rooms are left to care for women neglected by the abortion industry. The precise number of complications is impossible to measure because U.S. abortion complication data is so poor, and the aftermath of chemical abortions taken at home is not easily identified. The Food and Drug Administration requires only reporting of deaths from chemical abortions, while there is no national complication reporting requirement for surgical abortion. Due to the voluntary and short-term nature of U.S. abortion complication reporting, there will be no documentation of the long-term effects of these complications for these women. Will they suffer mental health complications from these experiences? Will they have difficulty achieving a future pregnancy or giving birth to a desired child? Or will cervical or uterine damage cause future pregnancy complications, increasing the risks for both mother and child? Risks including chronic inflammation leading to infertility, incompetent cervix leading to premature delivery, and abnormal placental attachment leading to premature placental separation or invasion.